Morning, selamat pagi, Prof. Sulis, Prof. Dr. Andri. Good morning, Bisek.
Selamat
Good morning,
pagi,
good
Baik,
morning,
Prof. Iko.
good day, good
Morning,
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 everyone. Greeting from Thailand.
morning, Bisek.
Oke.
Kap.
Terima kasih, Prof. Iko.
Iya. Selamat Kap.
สวัสดีครับ
Kita tunggu sebentar lagi ya, Prof ya. Beberapa saat lagi
Oke.
untuk memulai, Prof Iko.
Oke, oke,
Prof
no
Bisek,
problem.
we still wait for a few more minutes. We are
Yes,
waiting for the
please.
Dean of the faculty and also the chairpersons for the international partnership and collaboration of the 11 Maret University.
No problem. It is not 9 o'clock yet. We can wait.
Assalamualaikum, Prof Revi. Good morning, Prof Revi.
Assalamualaikum, good morning. Sorry, I'm off video.
Terima kasih, Prof, atas kehadirannya. Kami masukkan ke PIN ya, Prof.
Ya, ya.
Assalamualaikum, selamat pagi Pak Rino. Good morning, Dr. Rino.
Pagi dok, good morning. Ya,
Mohon izin karena sudah hadir semua, kita bisa mulai acara, Bapak Dekan, Bapak Ketua Officer Internasional untuk Relationship dan Partnership dari UNS, Prof. Iko dan juga Prof. Pisek Lumbiganon. Kami persilahkan kepada MC untuk bisa memulai. Terima kasih.
Assalamualaikum warahmatullahi wabarakatuh. Good morning and welcome to the World Class University Lecture on Saturday, the 13th of July, 2024. Today, we will cover topics surrounding infertility and sexual reproductive health that will be brought by special guest speakers. Before we begin with the event, I would like to thank all of you for taking the time to be here today, whether it be in the Zoom meeting or here on site at the Medical Faculty Building of Sebelas Maret University. I would like to say a special welcome to the Dean of Sebelas Maret University Medical School, Professor Dr. Rafiono, Pulmonary Medicine Specialist Consultant, the Head of International Office of Sebelas Maret University, Mr. Rino Adrian, PhD in Food Technology, our special guest lecturers, Professor Dr. Budi Wikeko, Specialist Obstetrics and Gynecology, subspecializing in fertility, endocrine, and reproduction health, an MPH from University of Indonesia, Professor Pisake Lumbiganon, MD, MS, PhD from Konkane University, and of course, our honorable beloved teachers who are our moderator and panelists for today's event, Dr. Adrianus Baknas, Specialist Obstetrics and Gynecology, subspecializing in fetal-maternal medicine as our moderator, and our panelists, Professor Dr. Sri Sulistiawati, Obstetrics and Gynecology Specialist, subspecializing in fetal-maternal medicine, Dr. Eric Edwin Yuliantara, Obstetrics and Gynecology Specialist, subspecializing in fetal-maternal medicine, Dr. Wisnu Prabowo, Obstetrics and Gynecology Specialist, subspecializing in fetal-maternal medicine, Dr. Nutria Widya Purna Anggraini, Obstetrics and Gynecology Gynecologist, subspecializing in fetal-maternal medicine and Masters in Health, Dr. Robert Redwan, Obstetrics and Gynecology Specialist, subspecializing in fetal-maternal medicine, and Dr. Lini Asetri, Obstetrics and Gynecology Specialist. To kickstart this event, let us listen to the Indonesian national anthem, followed by a short prayer on our own individual beliefs, so that today's event may go without a hitch. Before we start our Indonesian national anthem, I would like to ask the audience and our guest lecturers to please stand up to honor the national anthem. Thank you. The audience and guest lecturers may please sit back down. Continuing on to open today's event, please welcome Dr. Muhammad Adrianus Bahnas as the Chief of the World Class University Committee to open up our event for today with an opening speech.
Thank you very much for the master of the ceremony. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Good morning. It is an absolute honor for me to be here to represent the organizing committee of this event, the World Class University Lecture from Universitas 11 Maret. For the first time, I would like to give a warm welcome and special honorable to our Dean, the Faculty of Medicine, 11 Maret University, and then for the Director of the International Collaborations and Partnership of Universitas 11 Maret, for the Chair of the Department of Obstetrics and Gynecology, the Chair of Public Health Education Postgraduate Program of 11 Maret University, the Chairpersons of the Midwifery Education Program, 11 Maret University, and also for the panelists that already come here to join us from the Maternal Fetal Medicine divisions of the Obstetrics and Gynecology Department of 11 Maret University. And also for the Chair of Kalogisma, the alumni bonding of the Obstetrics and Gynecology Specialist Program from 11 Maret University, all of the college and all of the attendees from the students, the residence programs, the students from the PhD program for the public health, the students from the midwifery programs. And also for our distinguished lecturers, the international lecturers, thank you very much. It's already kindly accepted our invitations. First one for the Professor Budi Wiweko from Universitas Indonesia. He is now representing the chair of the Academic Senate of the University of Indonesia and also the president-elect of the Indonesian Society of Obstetrics and Gynecology. And then the second one, also our distinguished lecturers from Konkain University, Professor Pisek Lumbiganan. He is now as the WHO Directors for Research and Collaborations of the Reproductive Health. And he's also representing as the former president of the Asia Oceania Federation of Obstetrics and Gynecology. Thank you very much for your kindly acceptance for our invitations. As we know that the 11 Maret University is called to answer the challenge of and the need of the problems in the Indonesian society, Indonesian people. We know that the problems of the sexual reproductive health is one of the most challenging problems in Indonesia that need to be solved not only by Indonesia, but by having a collaboration internationally with others, with the broad overseas to make a difference. And as for today's lecture, we would like to have the new insight and also the breakthrough thoughts from our international lecturers, from Professor Budi Wiweko and Professor Pisek Lumbiganan, to share their knowledge, to share their experiences, and to share their best thoughts to solve the problems in our field, the obstetrics and gynecology. Of course, there is some specific topics that due to the amount of time, we'll focusedly discuss. The first one is regarding to the infertility, the challenges in Indonesia and challenges of the global. And the second one is how we are using the evidence-based medicine to solve problems in obstetrics and gynecology field, how to make clinical decisions, how to make a consensus, and how to make a public policy regarding for the evidence-based medicine, the best practice. So without further ado, I would like to welcome you all to this wonderful meeting. Let's have a fruitful discussions and please enjoy. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Dr. Muhammad Adrianus Bahnas, obstetrics and gynecology specialist, subspecializing in fetal-maternal medicine, as the chief of the World-Class University Committee for the very enthusiastic and optimistic opening speech for today's event. Next, we have the Dean of 11 Maret University Medical School, Professor Dr. Refiono, pulmonary medicine specialist consultant, with a welcoming speech.
Okay, thank you, Master of Ceremony. Assalamualaikum warahmatullahi wabarakatuh. Good morning to distinguished speaker, panelists, and also International Office Universitas 11 Maret. Also, all our colleges, students, and all participants. It is my pleasure to welcome you to this World-Class University's lecture. First of all, let us pray and praise to Almighty Allah Subhanahu wa Ta'ala, because of His bless and mercy, we can come together without any obstacle with the health condition. And to the events in Bonn, visiting professor 2024 podcast university lecture. And the second, I apologize for not being able to attend this event offline because I have outside segment. Let me express my deepest gratitude to all participants who have taken their precious time to attend this lecture. In particular, I would like to express my sincere appreciation to the invited lecturer from Department of Obstetrics and Gynecology Medical Faculty, Konken University, and from Universitas Indonesia. Today we are very lucky because we have a well-known our class expert speaker. Thank you very much for Professor Biseke Labikon PT, MTB, MSBSD, for your willingness to share your expertise in sexual and reproductive health. Good morning, Professor Biseke. I heard, nice to meet you, and I heard that he's currently and he has served a leader, and also Dr. Adrianus saying that you are director with a WHO collaborating center on research and reproductive health, and also you are also the former dean of medical faculty Konken University. Okay, I think we're not wasting this opportunity to discuss directly with him. And I would also like to thank you for Professor Wibiko from Department of Obstetrics and Gynecology Universitas Indonesia. Terima kasih atas kehadirannya. Who is willing to attend this event, and yes, currently I know is Director Medical Science, IMERI, and Universitas Indonesia, and also President-elect of Indonesian Society of Obstetrics and Gynecology. Okay, also in present here, a part of gynecology study program student, and also student from the midwifery, and also a student from public health, maybe public program, and so that we can simultaneously get mutual benefit for the world-class university lecture today. As my knowledge as a head of faculty, we always support scientific activities like this. I do hope that all of you will gather in fruitful discussion and sharing that encourage knowledge and maybe technology transfer. And hopefully this lecture can contribute to answering question and problem around problem the reproductive health. Okay, and for the closing, I, as the Dean of Faculty of Medicine, Universitas Maret, would like to thank the committee for organizing this event. And finally, I hope that you, all of you, will enjoy this wonderful lecture and gain the most benefit from it. Okay, thank you. Have a wonderful lecture. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Professor Dr. Rafiono, Pulmonary Medicine Specialist Consultant, for the heartwarming opening remarks. Last but not least, we have Mr. Rino Adrian, PhD in Food Technology, who is also the head of International Office of Sebelas Maret University, to offer a few words to welcome everybody here today into today's event.
Okay, thank you. First of all, Assalamualaikum warahmatullahi wabarakatuh. The Honorable Dean of Faculty of Medicine, Sebelas Maret University, Professor Dr. Rufiono, SPP, our distinguished speakers, Professor Dr. Budi Wiweko, and Professor Pisake Lumbi-Ganon, our moderator, Dr. Adrianus Pahnas, and Dr. Eric Edwin Yuliantara, Dr. Wisnu Prabowo, Dr. Nutria Widyapurna Anggraini, Dr. Robert Ridwan, and Dr. Lini Astetri, as well as Professor Sri Sulistyo for attending these events. Esteemed guests and all attendees, first of all, Alhamdulillah for Allah's blessings and grace that we can gather here today for the Universitas Sebelas Maret in Bonn Visiting Professor 2024 World Class University Lecture. So I'm deeply honored and grateful having here in this important event, which a testament to Universitas Sebelas Maret commitment to continually enhancing the quality of education and research at the international level. Today, we have the extraordinary opportunity to listen and engage with the renowned experts in the field. First one is Professor Dr. Budi Wiweko, SPOG, Subspecialist FR MPH. Thank you, Professor, for your attendance. And Professor Pisake Lumbi-Ganon, MD, MS, PhD. Thank you, Professor, for your attendance as well. As the chairman of the Academic Senate of UI with an outstanding reputation in the field of infertility, and as the director of the WHO Collaborating Center on Research Synthesis in Reproductive Health at Hon Hai University, Thailand, respectively. So the presence of these two prominent and remarkable figures is expected to provide new insights and inspire all of you to continue innovating and contributing to the field of health, particularly in reproductive health. So as an academic institution, we believe in the significance of nurturing global connections and facilitating the exchange of ideas across borders. So the events like this are essentials for us to enrich our academic environment as well as expanding our perspective and networks. I would also like to express my highest appreciations to everyone who involved in this organizing this event. I believe this event will be greatly beneficial for all of us, especially in expanding our networks and enhancing academic research quality at the Faculty of Medicine, Universitas Sebelas Maret in particular. This is a unique chance to learn from leading experts in the field of reproductive health. So please, all of the attendees, especially for those students, actively participate in this event by discussing new insights as well as giving tough questions to the respected speakers so that it will have a better academic experts in the futures. So finally, I would like to wish you all a fruitful event, and may today's activities proceed smoothly and bring significant benefits to all of us. Thank you. Assalamualaikum warahmatullahi wabarakatuh. Welcome, Professor Budi. Welcome, Professor Pisake.
Thank you, Mr. Rino Adrian, for the lovely welcome and also the encouragement for everyone present here today on site and online to be actively participating in this event today. Without further ado, let us hand over the spotlight to our beloved teacher and moderator for today's world-class university lecture, Dr. Muhammad Adrianus Baknas, obstetrics and gynecology specialist, subspecializing in fetal-maternal medicine consultant, to begin this event.
Thank you very much for the Master of Ceremony. And now we are heading to our main events for today's agenda. Is the lectures from our two respected speakers from international speakers, Professor Budi Wiweko and Professor Pisek Lumbiganon. For the first topics, okay, I would like to a little bit for the first lecture is Professor Budi Wiweko. Yeah. Okay. I'm sorry. Is this slide is shown on the audience for the online audience or not shown? So without further ado, if I'm reading all of the curriculum vitae of Professor Budi Wiweko, maybe it took a half day long to read, and also Prof. Pisek. So we are continuing to the agenda for the topic, the challenges of infertility treatment in Indonesia, the impact and the unmet need. We know that the fertility is a little bit tricky that we have to challenge because from the national health coverage, infertility is not one of the benefits for using the national health coverage, and the fertility needs very high cost for care services, also high technology. So how can we mix that up with the recent advances of knowledge and technology based on practice in Indonesia and also the challenges in global? Time is yours, Professor Budi Wiweko, to give your lectures for 30 minutes. Thank you.
Thank you very much, Mr. Chairperson, Dr. Adri. Very good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. It is really a great pleasure for me to be here, to be invited in this very wonderful event by Dr. Adri, and also thank you very much for the Dean of 11 Maret Medical School, and also our colleague, Professor Pisek, and all the panelists this morning. I will start our discussion today with the impact and the unmet need, and how the challenge of infertility treatment also in Indonesia. I start with the quote, the elephant in the rooms. It seems explain all the big problem in front of us, but we did not realize that this is a big problem, such as the climate change, population, demography, prosperity, economy, sustainability, fertility, and also family planning. If you look at this very interesting article by Professor John Aitken, he's a Nobel laureate in 2014. He's from Newcastle University in South Newcastle, Australia, and he strongly support our development of Indonesian Medical Education Research Institute in Faculty of Medicine, University of Indonesia. He's a named andrologist, and then a very interesting that he states that there is a steep declining of fertility rate in virtually every country on the earth, and then it is because this happened because of increasing prosperity largely through the mediation of social factors, and then also very clear that environment and lifestyle factors are the very crucial toward declining of fertility rate across the globe in the world. And if you look this figure, after reaching its peak in 1960, the rate of human population growth continues to decline. And then I think beginning in 1970, global population growth rate slowed dramatically. and now just over only 1% annually. And if we look the definition, the terminology of total fertility rate or TFR, it is explaining actually how many, the total number of the children that will be born to each woman during her childbearing years. Then we can see that in the 1900, actually the word total fertility rate is 5.7 children for every woman. And right now, I think most of the country is nearly below than or above the replacement rate 2.1, and then most of them even below than replacement rate 2.1. That is very dangerous. Actually, if you look, what is the factors influencing the total fertility rate? That driven by economic and social factors, and then also this combination environmental, lifestyle, and genetic factors, which could potentially damage the fecundity. So that's why the fertility rates was declining. This is also just published by Lancet in 2024, explaining the global fertility across 204 countries and territories, comparing 1950 with 2021. This forecasting 21 centuries. And it's very interesting if you look how the fertility rate, total fertility rate globally, and also in Southeast Asia. Where is Southeast Asia? Here is Southeast Asia. Then if you look this one, 2020, most of the country in Southeast Asia below than replacement rate 2.1. And then if you look our country, Indonesia, this is in 1950. Where is Indonesia? I think Indonesia is here. In 1950, our totality fertility rate is above 60. This is Thailand. P6 also almost 7. And then now in 2021, where is Indonesia? Here, Indonesia. Indonesia is here. Yeah, 2000. I think across almost near I think 2.1. And then the forecasting in 2100, Indonesia, our total fertility rate is below than 1.5. This is really dangerous. Really dangerous if we think about the sustainability of population. It should be at least the total fertility rate is never beyond that, never below than 2.1. And then this is also, we can see the rate of natural increasing calculated as the birth rate minus the death rate. We can see that the negative rate indicates that more death happen in the particular year and locations across the globe. Yeah, if you look this one, the total fertility rate is in more developed regions. More developed regions now is 1.5, less developed region is 2.1, and then least developed countries above 2. So particularly if we look the high total fertility rate in African population, you see, we can see here in African country, even more than 4, more than 5, but in the more developed region, mostly below than 2. And then in Asia, now 1.9. Could we imagine that very difficult for us to see later, we can to see the student in the elementary school and even in the junior high school because of very, very low total fertility rate. And then the decrease of total fertility rate is not synonymous with the decrease in fecundity, because the primary determinant in the short-term reduction of total fertility rate because of educational and socio-economic factors. And then in the long term, declining of TFR just influenced by combination of environment, lifestyle, and genetic factors, and then can be result as the permanent fecundity disorder. Then we can see before, I think a long time ago, the growing fertility crisis is related to food availability. But now, this theory, is not anymore, we can accept it, because the food availability has increased, but total fertility has fallen. Yeah, if you look this one for the developed countries, yeah, they can make immigration program as a temporary solution to keep population growth. Yeah, like China, yeah, in India, or maybe more developed countries, they have the population because of immigration program. And then this is very interesting that the state of high birth rate and infant mortality, as prosperity increasing, infant death declining, parallel to declining of total fertility rate and increasing of life expectancy. And then this condition will generate super age population. So population aging, now more than 20% of the population over 65. For example, Japan, Finland, Italy, and Germany, or even in Korea, it's really difficult for us to see the student, elementary school student, and a junior high school student because of increasing of aging population. And this is, I think, our challenge on all over the world, the population crisis. This is low total fertility with rapid depopulation, most likely Eastern European countries, but low total fertility with growing population because of immigration. It is happened especially in Canada, the country like Canada. And then what is the causes of declining human fertility rate? Number one is social factors. Most impactful in the short term because of growing urbanization, because of higher living expenses, and better access toward family planning and contraception. So that's why we should be very, very careful in making socialization of the family planning, the concept of family planning and contraception, because not every family, they need the contraception for inhibiting of the having a children. And then interesting evidence about education factors. By increasing in female literacy, it is positively correlated with declining in total fertility rate. Why it happened? Because higher autonomy concerning fertility associated with the confidence, regret health, and then presence of support from surrounding people. And having a child is not the priority of life. You can see here, adult family literacy rate and negatively correlate with total fertility rate. And then this is very dangerous actually for us in Indonesia also. Yeah, not so easy to solving this kind of problems. And then decreasing in marriage rate, low marriage rate, mainly in developed countries, also in Indonesia right now, in a big city like Jakarta. I don't know in West Java, in central of Java, but in Jakarta right now, even female, they are not willing to early marriage. They want to catch their career until more than 35, even above 40. Yeah, this is affected the increasing the fertility rate of poor. And then the third, this is environment and lifestyle is very important. High prevalence now is global male infertility because of obesity, because of changing lifestyle. There's smoking, endocrine disruptors such as the BPA, bisphenol in FDA now in US. All the plastic, all the food packaging should be BPA free because it's very dangerous with fertility. And then also similar component for female fertility. You see decreasing of fertility rate because of affected by environment. You can see here how the environment, lifestyle factor affecting human fertility. And then for the male, because of increasing the bad habits, the bad lifestyle like smoking will increase sperm DNA fragmentation. And this is not so good. Yeah, this is declining of sperm fertility because of changing lifestyle and environment, including also the climate change. This is for the fertility. You see the physical activity, sedentary excessive exercise. This is high total temperature, drug abuse, nutrition. Yeah, obesity. Yeah, we are what we eat. This is very related with declining of fertility. And then delayed childbearing and starting a family now. Yeah, in the big city, yeah, many women, Indonesia, I think the average of women to get married right now is about 28, 29 years old. In the big city like Jakarta, it's like this, the condition. Of course, this is related with the reduction in number and quality of egg cells, and then increasing the risk of delayed childbearing due to pursuit of education and career. And also industry of fertility, industry of obstetrics like IVF. Many people right now, many couples believe that no problem for them to get married late because we have the technology. We have IVF, in vitro fertilization, that will help us to solving the problem to get the children. But this is unfortunately, IVF industry is a big industry that correlate with the income of the patients. You see here, if the affordability of the IVF increase, of course the cycles also increasing, and then this is at vice versa. So it's very important that the affordability of IVF is positively correlated with the gross domestic product to every country. And then how the experience in China? China is the biggest population right now, number one in the world. Then the China, we remember one child policy, and then right now they're lifting the two-child policy. For the China policymaker, lifted one child policy to two-child policy, and then this is how it effect. This is only increasing the birth rate naturally, but not sustained, only increasing in the few of times and then declining afterwards. Yeah, this is the big problem as well, including in China. So this is the conceptual model of infertility prevention. The paper published by Posen in 2024. I think this is very interesting to see how we should do primary prevention. Very important. This one, interventions, pathway leading to reduce the risk of infertility by doing primary prevention, like education, lifestyle and behavior changes is very important. Optimizing when to start family, and then regulating reduction of workplace and environmental threats. This is the role of government, to make the regulation favor to have a children. Then this is secondary prevention, timely health seeking, early detection and facilitating access to the treatment, and then the tertiary prevention, access to the fertility care, and reduction in harmful fertility medical practices. This is very important, how we do the prevention, reducing the risk of infertility. And then this is indicator, increasing the fertility awareness and knowledge at the first birth, decreasing exposure to risk and hazard. This is very important as well, time to pregnancy, and then the quality of life for people with fertility problem. I think this is what we should do in global and also in our country, in Indonesia. And then this is the reality in our country right now. The total fertility rate in Indonesia 2.18, nil, very close to the threshold of replacement rate 2.1, and that's a little bit dangerous. Yeah, if you see also, this is age specific fertility rate among 15 to 19 years old in 2017 to 2022. Even we still, yeah, this is the double-edged sword. Yeah, we can find also the merit among the adolescents. Then how is the distribution of total fertility rate across Indonesian province? This is the average, 2.81. But you can see here, there are 8 provinces. The total fertility rate is nearly 2.1, and then even below than 2.1. Jakarta is 1.75. So it's really dangerous. If we talk about the sustainable population in Jakarta, also this one in Yogyakarta, in the west, this is in Central Java, 2.09. And then we can see here 5% in Papua, Nusa Tenggara, 2.7. So we can see here how the education is quite related with the total fertility rate in our country. Yeah. And then also, it's very good data that marriage trend in Indonesia is decreasing. And then the fourth trend is increasing. So this is also the factors that is not so good for our total fertility rate. And then how was the global population structure? Now Indonesia is number 4, 285 million, but in 2045, Indonesia will, I think, declining of population, and we become number 6, below than Nigeria and Pakistan. So this has happened. What happened in our country? And then if you look, this one is life expectancy rate in our country right now is 73 years old with total fertility 2.918. Yeah, this is the total fertility rate. The Thailand also is 1.3, Singapore 1, China is 1.3. Yes, it's a little bit dangerous for the sustainability of population in the world. And then how about dependency rate? Every country, every childbearing age populations, they have a pioneer, they have a, I think the good workforce that will support the children below than 15 years old, and then the elder above 65 years old. Sorry. And then what happened in our country? We can see the 2020, this is the lowest dependency rate, 44%. And then how is right now? I think right now we are 2025, yeah, the dependency rate is increasing. Why increasing? It is because increasing of elder people in Indonesia. You see here, increasing the elder people in Indonesia, even the children, because even the total fertility rate is declining, but this one increasing. So that's why dependency rate is declining, is increasing. So please be very careful to our country if you want to establish our nation. Then this is dependency rate across Indonesian province. Jakarta, of course, the lowest, but you can see here, Aceh is 48%. Then it's quite very, West Sulawesi is 49%. Even Nusa Tenggara is above 50%. So it's quite very because of population, because of demography. So if you want to establish our nation, what should we do? This one. Very important. Yeah, it's very important. This one, scale, the upscale, rescale, and then health. So aging, healthy aging, and then productive in reproductive year, aging people. This is very important. What should we do to optimize the bonus of demography in our country? And then also it's quite related with the IQ in our country. Yeah, it's unfortunately Indonesia is 130 position in IQ, and then also the human capital index ranked 6 in Southeast Asia. Yeah, it is because of the strategy for establishing the bonus demography is quite important in our country. You can see here, marriage and divorce increasing. And then right now, this is the pyramid of Indonesian demography in 2080. And then if beyond 2030, it's very, very dangerous because of the children below than 15 maybe become less and less, and then the aging people increasing. So it's like the triangle, the 5%. And then also this is the very important, the endocrine disruptors, what I mentioned before, that decreasing, affecting the fertility rate. Yeah, all the endocrine disruptor like BPA, dioxin, increasing reproductive diseases such as ovulatory dysfunction, endometriosis disease, cancer as well. This is not so good for our total fertility rate, and also for the children in the future. We can see, and then the very important one, the window of exposure happening during the pregnancy. So the first 9 months is shape the rest of your life. Yeah, this has happened because of endocrine disruptors, because of epigenetic program, because of environmental, and then our lifestyle. You can see this is exposure. So that's why the regulation from our country also is very important. And then see the climate change, also the impact of climate change on human health. is not so good. The increasing of temperature, they will declining with negatively correlate with over and reserve declining. This is not so good for every country. And then we can see here how the 10 years of infertility services in our country, we can say this is just published in 2023. Yeah, this is what happened in our country for the fertility services across almost 70,000 couples across the province. This is the services. Yeah, even in our country, you can see here, the male fertility is the biggest problem. So please be very careful to the lifestyle and environment. Number one is male factor affecting declining of fertility rate. And then please be very careful this one. Yeah, you see in the coverage, IVF coverage, ideally coverage 600 until 700 cycles IVF per 1 million population. Right now, Indonesia only 55. Yeah, compared to the Thailand 500, Vietnam 600. So we're very far from the ideal coverage. This is also our challenge and our barrier to increasing, to solving the problems in the fertility, in the demography, in the populations. And then this is all the problem in our country right now. Yeah, even the target right now is total fertility to 2.18 right now, and then the marriage rate in this the teen pregnant, the teen marriage, adolescent marriage below than 18 years old right now is 11%, unmet family planning is 18%, and then teenage pregnancy is 24%, maternal mortality, infant mortality, and anemia in pregnant women, and then stunting. These are, I think, our problem, our big problems in the health reproductive. And then what is the technology trying to solving this problem? You see, this is the egg freezing, the fertility preservation, how the technology trying to bridge the gap to solving the problem for every couple that want to delay the marriage and then delay the pregnancy. There is the fertility preservation. Also in Indonesia, we have this kind of services. And then this is the big concept. The big concept of family planning is very important in our country, especially starting from adolescent, adult, periconception, pregnant woman, and then healthy menopause. We should educate a woman to understand, to record their menstrual cycle, to know how is the puberty, sex differentiation, reproduction, and then marriage, immunization, vaccination is very important. Premarital screening. Yeah, our goal is to establish the human capital development, the nutrition, and then the contraception. This is the concept that is very important. Now, the challenge of the family planning, not only the contraception, but to educate a woman to understand how to start the family, when to start the family. So when we educate a woman, we educate a nation. I think this is very important quote. And then as a take-home messages, we know that fertility rate right now decreased dramatically across the globe. Also in Indonesia right now, our total fertility is 2.18. And then even 8 provinces are below than 2.1. And then it's very important, this is, I think, delay of childbearing, more prone to infertility. And then environment, including climate change and lifestyle, exposure to endocrine disruptors that mainly happen during embryonic and fetal period. This is very important. Then education also is negatively correlate with the total fertility rate. And then this is cause of the declining of fertility. This is sperm, male factors. And then in Indonesia, I think the IVF coverage still below than ideal. Right now it's 2.18. So I think very important. We should decreasing dependency ratio. It's below than 44%, and also keep our total fertility rate around total replacement rate, around the ideal replacement rate 2.1. This optimized demography, bonus, and then this is the other province that still have relatively higher total fertility rate. So the concept of family planning should be approached personalized and precise. It's quite depend on each province problem. So the problem such as elephant in the room. Yeah, see, this is the obvious that everyone knows about, but no one mentioned and want to discuss, such as the family planning, demography, and fertility problem in our country. Thank you very much for your kind attention.
Let's give a big applause to Budi Wiweko. Thank you very much for very insightful lectures, Professor Iko, so that the elephant is not only in Waikambas, but is now in our room in Indonesia and all for the globally, internationally, worldwide. So this is a very, very like interesting question for of us to answer. And we will have the later on discussion with our panelists and also participants on site or online. So we are continuing ahead for the second lectures from Professor Pisek Lumbiganan from Khon Kaen University. Professor Pisek Lumbiganan is the professor in obstetrics and gynecology of the Khon Kaen University, now as the director of WHO collaborative for research synthesis in health, in reproductive health. And he is also the past immediate president of the Asia Oceania Federations of Obstetrics and Gynecology, and also the former dean of the Khon Kaen University. So without further ado, the Professor Pisek Lumbiganan will give topics about how to implement the evidence-based medicine in the field of the sexual and reproductive health. Time is yours, Professor Pisek Lumbiganan, for 30 minutes. Thank you. I'm sorry, you are still muted, Prof. Can you unmute the?
Yes,
okay.
Okay, thank you very much.
Thank you very much.
Thank you very much, Adrian, for your very kind introduction. I don't know whether Professor Livono, the dean, has already left, or Mr. Lino, but I would like to acknowledge them for joining our conference today. And Budi, I enjoy your fantastic lecture very much. Thailand is facing similar, even worse situation about the population compared to the Philippines. Edith, I cannot move the slide. Let me try again.
Please.
Okay, I would like to thank Department of Obstetrics and Gynecology, Faculty of Medicine, University of Ceballos Maret, for inviting me to give this lecture today. I would like also to thank the International Clinical Epidemiology Network and the Rockefeller Foundation and University of Pennsylvania, who gave me the opportunity to have a training in research methodology so that I can do the research properly. And Department of Sexual and Reproductive Health of the World Health Organization in Geneva, Switzerland, for inviting me to participate in their research activity over the past 30 years. And finally, I also would like to thank Cochrane for allowing me to participate and collaborate with them in the research synthesis activity. I don't have any conflict of interest in my presentation this morning. This is the outline of my presentation, which will cover concept of evidence-based medicine, research synthesis, Cochrane, formerly called as Cochrane Collaboration, Cochrane Library, Cochrane, Thailand, an example of evidence-based practices.
Excuse me, Professor Pisek Lumbiganan.
Yes?
We are not seeing your share screen for the
No?
presentations.
I'm so sorry. How can I do that? Maybe let me try again. Can you see my slide now?
Okay, now we are gladly seeing your slides now.
I'm very sorry about this technical problem. This is the outline of my presentation. Are you hearing and seeing my slides?
Yeah, fantastic, Prof.
Thank you very much. I'm sorry. What is evidence-based? Evidence-based medicine is the process of systematically finding, appraising, and using research finding for the basis of clinical decision-making. What is evidence-based medicine? Evidence-based medicine involves making decisions about the care of individual patients based on the best research evidence available, rather than personal opinion on common practices, which may not always be evidence-based. This is the definition that kindly issued by the National Institute for Health and Care Excellence, or NICE, from the UK. Why is evidence-based medicine important? As clinicians and healthcare professionals, we want best possible care for our patients. Keeping up to date is difficult. New evidence from research is often slow to be implemented. Established practices persist even ineffective or harmful. And nowadays, there are increasing issues of medical lawsuits in many countries, including Thailand, and I also believe in Indonesia as well. Professor Archie Cochrane, who is the world authority in evidence-based medicine, he mentioned that it is truly a great criticism of our profession that we have not organized a critical summary by specialty or subspecialty, and it has to be adapted periodically by relevant randomized control trial. Before the period of research synthesis, this is the quality of evidence. Number one is evidence obtained from at least one properly designed randomized control trial, followed by evidence obtained from well-designed control trial without randomization, and then cohort case control study, case series, multiple interrupted time series with or without intervention. And the least quality is from opinion from our respected authorities. What are the problems that we are facing? As healthcare personnel, we need update information. Textbooks are out of date sooner. When I was a medical student, I was also using William Obstetric. At that time, one edition can be used for more than 5 years. But now, maybe only every 3 years, they have to update the new edition of the textbook. Journals are disorganized and limited. We have too much information. Not all of them are good, so we have to need the critical appraisal skill to know which one is good so that we can follow them. We have time limitation. We have so many responsibilities. So as time passes on, our knowledge and performance deteriorate. Let me outline briefly about steps in conducting research. The first and most important step is to identify appropriate and good research questions. Usually for the intervention, we use the PICO, P stands for population, I intervention, C comparison, and O outcome. If we can define research question like this, it will be very clear. And our research will be very clear, outcome will be very clear. And then before doing further research, we need to conduct systematic review to refine research question. Then we have to select appropriate study design, develop research protocol. I would like to strongly recommend you to get familiar yourself with Equator Network reporting guideline, in which they will give you step-by-step or checklist how to cover in your protocol. We need adequate sample size, so we need to calculate our sample size. We need to identify our research team. And nowadays, because of the research question is very tight, usually we need collaborative study to answer our research question within a reasonable period of time. Then we finalize our research protocol, apply for ethical approval, submit for grant. Then we execute research, including recruitment, data collection, data analysis, and interpretation. We then disseminate the result of our research, either by presentation or publication. Again, I strongly recommend you follow the reporting guideline developed by Equator Network. The last one is also very important. It's about implementation of research. I'm sure that you agree with me that conducting research is difficult, but believe me, implementation of research is more difficult. So now the World Health Organization is focusing on another form of research, which is the implementation research. Research, when we have research finding, theoretically, ideally, we have to do research synthesis so that we can have the critical summary that was requested by Professor Archie Cochrane. Then we can develop clinical practice guideline, implement our clinical practice guideline, doing our audit and feedback so that we can refine our research again. Research synthesis is therefore under the concept of that the result of a particular research cannot be interpreted with any confidence unless they have been considered together with the result of other study, addressing the same or similar question. Research synthesis is therefore a process through which two or more research are combined with the objective of to summarize evidence related to that research particular question. Research synthesis is needed not only to reflect the cumulative nature of science, but also because the volume of research is overwhelming. The quality of research is very variable. So we have to do critical appraisal to choose only the valid research result. Access to report of research is often haphazard and often biased. So we have something like what we call publication bias. And one of the most important issues is that most studies are too small to be meaningful by itself. So we have to combine the result of research together. So research synthesis consists of two very important processes. The first one is systematic review. I put plus or minus here, meta-analysis. Because from systematic review, when we obtain research, sometimes we could not conduct meta-analysis. For example, if we have only one randomized control trial, we cannot do meta-analysis. And if the result of the research are very much heterogeneous, it is not appropriate to do meta-analysis to combine the result together. Let me give you one example of meta-analysis after systematic review. This slide shows you the forest plot about the evaluation of corticosteroid in preterm pregnancy, preterm labor, to prevent for respiratory distress syndrome in the newborn. You see that we have about 20, in fact, it is 18 studies that we include in this systematic review. Let's focus on the first one. It was conducted in Amsterdam in 1980. In the experimental group here, we have 64 mothers with preterm labor and who got corticosteroid, and 11 of their newborn got respiratory distress syndrome. In the control group, there were 56 mothers and 17 newborn got Lepers syndrome. This is the Peter-Oz ratio or relative list, and this line is 1. The point estimate is here on the left-hand side of the line 1. So it seems that receiving corticosteroid reduced the risk of Lepers syndrome. But the result of this study was not statistically significant because the upper limit of the 95% confidence interval exceeds 1. Let's focus on the second one, which was conducted in Auckland in 1972. 532 mothers received corticosteroid. Only 49 of their newborn got Lepers syndrome. In the meantime, 538 mothers did not receive corticosteroid, and 84 newborn got Lepers syndrome. You see the point estimate here. Again, on the left-hand side of the line 1, it indicates that corticosteroid has protective effect on Lepers syndrome. And this study shows statistically significant. It is obvious here because of the much bigger sample size in the second study compared to the first one. It made the result of the study statistically significant. If you follow all of this, you will see that most of the study gave the direction of the result towards the protective effect, but very few of them reached the statistical significant level, mainly because of the inadequate sample size. Now, let's focus on this diamond-shaped sign here. This is the result of the meta-analysis, in which they combined the result of these in-group studies together, and it gave them almost 2,000 participants in the experimental group as well as in control group. You see that the summary of the result is very precise and very concise. It indicates very clearly that for mothers with preterm labor, if they got corticosteroid, the chance of their newborn to have Lepers syndrome reduced significantly. So this is the critical summary of the research synthesis from systematic review and meta-analysis. So we developed clinical practice guidelines that all mothers with preterm labor should receive corticosteroid so that we can save life of many newborns. And these interventions save millions of newborn lives. So this is the very excellent example of the impact of systematic review and meta-analysis in healthcare. I showed this slide before the period of research synthesis. Randomized control trial was considered to be the #1 quality of evidence. Now, research synthesis of randomized control trial is considered to be the #1 of the quality of evidence. And now many organizations, including the World Health Organization, use the result of research synthesis of randomized control trial when they issue their recommendation, which I will elaborate later on. Remember that I described you about the criticism of Professor Archie Cochrane 30 years ago. Then the British government follow Professor Archie Cochrane comment, and they established one of the organization called National Perinatal Epidemiology Unit at the University of Oxford in the UK. And the mission of this unit was to do research synthesis, evaluating intervention related to pregnancy and childbirth, in which Dr. Ian Chalmers, later on became Sir Ian Chalmers, was designated to be the director of this unit. Ian and his team spent about 10 years before they can develop the first Oxford database perinatal trial, reporting the evaluation of various interventions related to pregnancy and childbirth using research synthesis. And then it was very well accepted in the UK as well as other parts of the world. So they expand the scope of this research synthesis to cover other specialty and subspecialty. And they developed at that time Cochrane collaboration, which is now Cochrane. And the UK Cochrane Center was the first UK Cochrane Center at Oxford University in the UK. And they managed to establish electronic journal called Cochrane Library. I'm sure that most, if not all of you, are familiar with the systematic review published in the Cochrane Library. This is the website of the Cochrane. And the vision of the Cochrane is trusted evidence, informed decision for better healthcare. They also promote translation because about 10 years ago, they evaluate that language is one of the barriers for healthcare professionals to have access to trusted evidence to make informed decisions. So they promote translation of Cochrane review into various languages, including Thai. Now, Professor Detti at Gadjah Mada University is also translating Cochrane review into Bahasa. This is the picture of the Cochrane Library. This is example of Cochrane review that my colleague and I conduct a few years ago, which was on prophylactic antibiotic for preventing infection after continence surgery in women with stress urinary continence. This is the structure of the Cochrane review. They have structure abstract here. One of the unique characteristics of Cochrane review is that they also have plain language summary, so that plain people, lay people, can understand what is available in Cochrane review related to these particular topics. They also have summary of finding table, in which they summarize the finding into easily understandable summary of finding table, including patient population, setting, intervention, and comparison group. And they describe for each outcome. This is the absolute effect, relative effect, number of participants and study, certainty of evidence, which grade from high to moderate, to low, to very low. So that you can know that, for example, for this particular outcome, the evidence that we have was only at low quality, very low quality. The impact factor of the Cochrane review recently, it was 8.4, which is one of the leading biomedical journal in the world in terms of the impact factor. Let me give you example of the implementation of evidence-based medicine in sexual and reproductive health. About 20 years ago, I have a privilege to work with another 3 countries in Southeast Asia. Therefore, we include 4 countries, including Indonesia, my colleagues at Gadjah Mada University, heading at that time by Professor Muhammad Hakimi, now with Dr. Owa, Dr. Detti, and University of the Philippines, and Malaysia and Thailand. With the collaboration of 3 universities in Australia, Sydney, Adelaide, and Melbourne and Monash University. We obtained the funding from Wellcome Trust to implement evidence-based practice in Southeast Asia. We call our study Sea Orchid project. And we also have the research capacity strengthening in this activity. I'm sure that you are familiar with vacuum extraction. Vacuum extraction is still recommended as the assisted vaginal delivery procedure when women need to be assisted during their vaginal delivery. And when I was medical student, as well as a resident and junior staff, I was taught by my professor that you have to gradually or stepwise increase the negative pressure before you can pull the fetal head out. So we use stepwise method of negative pressure for a long time. And during this Sea Orchid project activity, one of my colleagues have had a research question. Is rapid negative pressure application is effective and safe as stepwise method? Because by stepwise method, we need about 8 to 10 minutes to create enough negative pressure. Can we do that in 1 to 2 minutes? And we went to the Cochrane Library and we did not find any Cochrane review on this particular issue. So we proposed to Cochrane to to conduct this Cochrane review on this issue. And we found that there was only one trial that we can include in our Cochrane review, involved only 94 women. The duration of background procedure was reduced by about 6 minutes. There were no significant difference in terms of maternal and neonatal outcome. So we conclude that we don't have enough evidence to support the use of stepwise or a rapid negative pressure application. So what should we do next? We need to conduct randomized control trial. We calculate the sample size, and we need 660 women to be included in our randomized control trial to have enough power to evaluate this research question. So we need multi-center study. It took us only for 2 years before we can finish our multi-center randomized control trial, comparing rapid versus stepwise application of negative pressure in vacuum extraction assisted vaginal delivery, a multi-center randomized control trial, non-inferiority trial. And we update our Cochrane review to include our randomized control trial. And we conclude that we recommend rapid negative pressure application. New York Loiter Health quote our study in their headline on this. William Obstetrics used both our primary study, multi-center randomized control trial, as well as our Cochrane review as their reference in their textbook. The latest one is on the 26th edition. So the study that we conduct, both the primary study and Cochrane review, were used as references in William Obstetrics. I was involved in 42 Cochrane reviews, but I was the principal reviewer only into Cochrane review. For the other 40, I recommend, I stimulate, I help my colleagues to do this Cochrane review because I believe that it is very useful. I will show you how useful are they. This is the first one this is one of the Cochrane review that I did with Professor Mohamed Hakimi, or Dr. Mario Festin, Dr. Jackie Ho, and we published this in the Cochrane Library. And about the breastfeeding education in increasing breastfeeding duration. And it was used in the WHO recommendation on protecting, promoting, and supporting breastfeeding in facility, providing maternity and newborn services. The WHO recommendation on intervention to improve preterm birth outcome also use Cochrane review that my colleague and I did as their reference in their recommendation. The WHO recommendation on preventing and treatment of maternal and perinatal infection, in which I was one of the guideline development group, they also use these Cochrane review that were conducted by my colleague and I. There are 4 here, another 2 here, it has their differences. So our Cochrane review have been quite useful for the World Health Organization to use as their reference. Because of my publication and especially for my Cochrane review research synthesis, I was ranked as one top 2% scientist by Stanford University a few years ago. We were designated as the WHO Collaborating Center for Research Synthesis in our reproductive health because of our work, especially on the research synthesis on quite a number of sexual and reproductive health issues. And recently, we were also designated as the WHO lead hub to do research capacity strengthening for countries in Southeast Asia. And we are working with my very dear colleague, Professor Detti from Gadjah Mada University in doing this research capacity strengthening. These are the research hubs that were designated by the World Organization. In Asia, there are 2 hubs, one at Khon Kaen University, where I'm based, and the other one at Hanoi Medical University. This is the activity about Cochrane Thailand. We also take part in this role to shape healthcare practice within Thailand and beyond. We organized a workshop in Indonesia as well a few years ago, in Vietnam, in Japan. My take-home message for you this morning is, as healthcare professionals, we need lifelong learning. I strongly advocate the use of routine to research. That is to conduct research based on your routine work. You have to use clinical question, PICO. You have to do literature search. I recommend to you to do systematic search, working with Cochrane review, have comprehensive search, list of bias assessment, certainty of level, data synthesis and interpretation. If there are not enough evidence, we need to do evidence generation. We need to have appropriate study design. We need to have collaboration using multi-center study. We have to update our evidence. Very importantly, we need to implement our research appropriately. And I think as the healthcare teacher, we need to be good role model for teaching and conducting research. Thank you very much for your very kind attention.
Thank you very much, Prof. Pisek Lumiganon. Please give a kind appreciation, a big applause for Prof. Pisek Lumiganon. It is very interesting to see on how, starting from the personal questions, could become a national policy and become a worldwide policy, and also taught in the textbook, starting from how to make a good research synthesis from the personal question. So please, for the participant, you need to think more, ask more, and answer more using the research synthesis started from your daily practices. It's very, very interesting. Thank you very much, Prof. Pisek. So on behalf of the organizing committee, I would like to inform to all of the participants, no worries for the very great lecturer slides. It will be shared. The lecturers has already kindly shared to us the presentation slide, and it could be downloaded from the chat box or by contacting the organizing committee. And it's very nice to make an addition for your knowledge from the presentations. And now heading for the discussion, we think we are still on the track for the time being, and we have around half hour for a discussion. I would like to introduce first our panelists. The first one, Professor Sri Sulistyowati. Can the admin add Prof. Sulis to the join for us for discussion, please? The pin for the spotlight. Please no. Prof. Sri Sulistyowati, she is now served as the chairperson for the Academic Senate of 11 Maret University. She is the former head of the divisions of maternal fetal medicine, Department of Obstetrics and Gynecology, 11 Maret University, and Rumah Sakit, and for the Dr. Moardi General Hospital. And also she is the former vice director of the 11 Maret University Hospital. And now she is also in charge as the chair, as the president of the Indonesian Society of Maternal Fetal Medicine. And then the second panelist, the second panelist is Dr. Eric Edwin Yuliantara. Dr. Eric Edwin Yuliantara is now the chairperson for the medical staff in Moardi General Hospital and partner in the divisions of the maternal fetal medicine of the Obstetrics and Gynecology Department. And then the third one, Dr. Wisnu Prabowo. Dr. Wisnu Prabowo is one of our senior consultant in the maternal fetal medicine divisions of Obstetrics and Gynecology Department, Moardi General Hospital, 11 Maret University. And then the fourth one, the Dr. Nutria Widyapurna Anggraini. She is the consultant on maternal fetal medicine divisions of Obstetrics and Gynecology Department, 11 Maret University. And Dr. Robert Ridwan. He's the one of our latest consultant in maternal fetal medicine divisions of obstetrics and gynecology department, 11 Maret University. And then the last one, Dr. Lini Astetri. She is also from the maternal fetal medicine divisions of obstetrics and gynecology department, Dr. Muari General Hospital, 11 Maret University. Maybe for next year, she will join the fellowship for the consultant of the maternal fetal medicine to study. And now we are having discussions starting from the panelists. We will give time for Professor Sulistiawati to give challenging questions or lecture from the speakers. Please, Professor Sulistiawati.
Thank you, Dr. Adri. Assalamualaikum, Prof. Iko. Suara saya terdengar, Dr. Adri?
Jelas, Prof?
Jelas, Prof.
Very good.
Okay.
Ya, baik. Mohon untuk Dr. Iko ya, dari yang dipaparkan tadi kan banyak faktor dari penyebab infertilitas di Indonesia ya. Bagaimana kita bisa memilih manajemen yang memungkinkan, yang paling memungkinkan untuk keberhasilan fertilitas, seperti mungkin bekerja sama dengan pemerintah, mungkin tentang undang-undang pernikahan, mungkin ya, karena banyak di pernikahan-pernikahan yang usianya lanjut gitu ya, sehingga mungkin faktor fertilitasnya berkurang. Kemudian juga tadi salah satu penyebabnya kayak banyak anemi pada wanita usia muda, apalagi wanita hamil gitu. Dari seperti itu kita pilih yang mana yang paling memungkinkan untuk di Indonesia, Prof. Terima kasih. Lanjut yang ke Prof. Lanjut apa sendiri-sendiri, Dr. Adri?
Boleh, Prof. Bisa, silakan, Prof. Please.
Baik. To Prof. Pisake, I want to know about what basic implementation of EPM in sexual reproductive health can be applied in developing countries like in Indonesia. Thank you.
Thank you, Professor Sulistiawati, for the challenging questions. So for the first occasion, please, Professor Budi Wiweko, to answer the question from Professor Sulistiawati regarding how can we can manage between the policy from the government and our abilities as the clinicians, practitioners, and also how about the university positions for measuring up this condition? Thank you.
Yes, thank you very much, Dr. Adri and Dr. Julis, for very interesting questions. As I mentioned in the lecture, that very important right now, we are starting with the prevention program. The meaning of prevention, we can start from the primary prevention. Then the primary prevention, we should educate a woman and also educate a male. Yeah, because of very importance that nowadays, at the moment, 35% of the cause of or etiology of infertility because of male factors. So that's why it's very important we should educate and advocate the male for the lifestyle. Therefore, be very careful for the dangerous lifestyle. Let's say, for example, wearing the tight underwear and then the cycling in the long distance cycling, everything that increasing the temperature surrounding throttle, it will damage the sperm quality and also the sperm quantity. So that's why it's very important to avoid the lifestyle that will increasing the damage of the sperms. And then the second thing for the female, also very important, we should educate the female when the optimal time to starting the family, optimal timing to have a children. It is because related with the quantity and also the quality of age. there's a golden age of the female that it should be at least below than 35 years old to have the children. I think this is the very important, the primary prevention, and also making the woman realize the awareness to have the menstrual cycle, menstrual cycle that should be regular menstrual cycle. So they should have menstrual diary to have a note when the menstruation is coming, how long the menstruation, any symptoms or not. This is the simple way. This is a simple way to educate a female, educate a woman about their reproductive health. I think this is even we can delegate, this is the task of the responsibility of educate and advocate a male and female to the primary physicians, like GP and also maybe midwife and also the nurse in the primary care. I think this is the very simple way for us to advocate when the best time to starting family. I think this is my comment, and also the other task to advocate the government is very important. How the regulation can facilitate us to have a good time to starting the family in our country. Thank you.
Yeah, very interesting.
Terima kasih. Oke.
Prof. Iko, ya. The one that is very difficult is to change the evolving mindset, yeah, regarding that the marriage and to have a children is not a priority nowadays for the Gen Z. It's very difficult how for the government can give a stimulation for them to think different. Is it necessary to give like stimulations for having a free to go school tuition, free to have healthcare services for a couple that will have children, at least 2 or other? It may be a challenges in the upcoming years, I think.
Yeah. This is the sexy issue. The problem in our community, they say they are unwilling to have a children, because the high cost for the health and also high cost for the education. I think this is a mandatory for the government. We should advocate the government that is supporting the education and then supporting the health facilities and health. The cost for the health and education is mandatory for our government to support our citizens and then our population to have the children. This, I think, a very good strategy for every country. I think almost every country in the world right now, they did this beautiful program. Instead of giving an incentive, you subsidize the fertility program. Let's say, for example, in the countries such as Korea and in Japan, Taiwan, they did very well this kind of programs. And also, I think nowadays in Indonesia, in such a big city like Jakarta, I think we should also think about this very beautiful program. Thank you.
Thank you, Professor Iko, Professor Budi Wiweko. Now continue to Professor Pisek regarding to Professor Sulistiawati questions. To relate, how about the evidence-based medicine in recent knowledge of yours, your best knowledge regarding for answering the questions on the discrepancy on the fertility rate, the disparity, the unmet need? Is there any data for the evidence-based medicine that can be as a stimulation for the upcoming policy for the government and also for the societies like healthcare services?
Thank you very much for this very challenging question. Unfortunately, my subspecialty is focusing mainly on maternal and fetal medicine. So I don't keep myself updated on the issue of fertility promotion, which is in fact also a very serious problem here in Thailand. The government is implementing many interventions without the evidence-based evidence to support those interventions. But I think there are countries in the Scandinavian in which they support more about the need for blessing the child after delivery. And I think that is one of the main challenging for young couple when they have children. It is very costly and time consuming for them. And that is, at least in Thailand, one of the main reasons that they don't want to have baby. But I admire my very dear colleague, Professor Butti, that you are very comprehensive in following this literature. I think also Professor Sulis Totobati also asked me about the issue of implementing evidence-based in developing country.
Yeah,
Yes.
correct, yes.
Yes, correct.
Let me also answer that question. In fact, we have been doing that almost 20 years ago. But I have to confess you that not in a very wide scale. We collaborate with Gajah Mada University. At that time, also my very dear colleague, Professor Muhammad Hakimi,
Okay.
and then later on to Dr. Ova and Dr. Detti.
Yes.
And Detti is now convening Cochrane Indonesia at Gajah Mada University. And they are conducting Cochrane review on some issue. Maybe we have to collaborate more and expand more about these activities among other institutes in Indonesia. And I think Cochrane Indonesia and Cochrane Thailand will be more than happy to do that. So let's do that together.
Yes.
Thank you very much,
Thank you.
Professor Pisak. This is a very interesting invitations for us to collaborate together for 11 Maret University. We would like also to have a big collaborations for research synthesis that can give some new color in how we have different problems compare for between the cities. Yeah.
Adrian, let me add one more issue. Research synthesis is a low-cost research. We don't have a big budget in doing research synthesis. We need our brain, our enthusiasm, and our work to do the research synthesis. We don't have big budget for that. So I consider research synthesis as a low-cost research. Thank you.
Thank you very much. So we are hoping that this will be heard from the student of PhD student and the master's student in the public health also that come to join us also for this event and can be one of the option to doing the research for their educations, to finish their educations, not only to think about the make the experimental or some costly research, but very high impact with low cost research. One of those is the evidence-based research synthesis. Yes, Professor. Thank you very much. So we are continuing. Professor
Thank
Sulis,
you.
is there any other question, Professor Sulis?
Oh, enough.
Thank you. Thank you very much, Professor Sulis, for the first term for the discussion. And the second one, Dr. Eric, would you like to give questions, or Dr. Wisnu Prabowo? Dr. Eric.
Thank you, Dr. Adri. Yeah. Assalamualaikum. Thank you, Dr. Adri. Maybe actually I don't have a question after I follow this meeting from slide Prof. Iko and Prof. Pisak. Many questions that's come to me before the both of our professor give all of the answer. Actually, about the question from my patient or from our community, about the why measurement of fertility is more complex compared with mortality. Maybe Professor Iko and Professor Pisak can explain more detail about this question, because in community sometimes they ask to me and I answer based on what I know. Thank you, Dr. Adri.
Thank you, Dr. Eric. Please can give an answer for Professor Iko and Professor Pisak, please.
If I'm not mistaken, so your question is about the how to define the fertility, because I'm not so clear about the question. How to measure, how to how how to define the fertility, or how to measure the fertility? You mean like that? Do you mean like that?
Yeah, yeah.
Okay, okay. Yeah, thank you very much. I just trying to answer your question based on the evidence. So if we look the, let's say, if we look the 100 couples who have getting married, and then within 6 months, 75% among the couples, they will have a children. They will get the pregnancy after 6 months. And then after 12 months, if they are having a sexual intercourse regularly without contraception, after 12 months, 85% of them are getting pregnant. So it means after 12 months, there is a 15% of the couple is not getting pregnant yet. And then if we look further into detail, the fecundity rate, the fecundity means the probability of the couples to get pregnancy every menstrual cycle. The highest fecundity is the first 2 months after marriage. The highest fecundity, 40%, they have in the first 2 months of the marriage. It means in the first 2 months after getting married, the probability to getting pregnant is 40% in one menstrual cycle. However, after the 12 months of getting married, the fecundity dramatically dropped. Only 3 to 5% the probability to get pregnant after 12 months getting married. So that's why, based on this prevalence, based on this evidence, to define the fertility, if the couples define or the couples classified as infertile couples, if they are already getting married at least 12 months, having sexual intercourse regularly without contraception. And then the regular means the sexual intercourse conducted within 2 until 3 times a week. So I think this is the way we can explain to the patient why they are classified as infertile couples. Hope it is answered your question. Thank you.
Thank you, Prof. Absolutely clear about your explanation.
Thank you.
Prof. Pisek, would you like to make some addition regarding
I don't have any additional after Budi excellent answer. Thank you.
How about the contraception, Professor? If we are saying that our fertility rate is decreasing dramatically, but in other hand, we're still doing the contraception. How it can be matched the unmet need for this kind of situation?
Maybe I can give information on this. In Thailand, the fertility rate among adolescents is not low. And in fact, it is too high. So we are promoting long-acting contraceptive among adolescent mothers after delivery. For example, we give immediate postpartum insertion of the implant before they leave the hospital for these adolescent mother after delivery. So we still need some contraception for some specific group of population. Thank you.
Very fantastic answer, Professor Pisek. It make very clear for us. Okay, now
I will add
please.
some comment also about this kind of question. Dr. Adi is very interesting. So that's why in my lecture I mentioned about the personalized approach in family planning. So in some province in Indonesia, 2.7 even 2.8 the total fertility rate. So in this kind of region, we should enhance the family planning services. Most likely is like Pisek mentioned, long-acting reversible contraception. And then on the other hand, for the province with the total fertility rate is among 2.1, 2.2, the contraception is very important to stabilize, to control the birth rate. So the total replacement rate is still the same. It's about approximately 2.1. But in the region when the total fertility rate is quite low, 1.6, 1.7, like in Jakarta, you should be very, very careful. Yeah, for the couples they have 2 children or 3 children, of course, we advocate them to use contraception. But for the young people, young men or female and male who's not getting married yet, and then who have not getting pregnancy yet, we should advocate them to have a children soon. I think this is what we call personalized approach in family planning. Thank you.
I think this thought should be heard by the BKKBN in Indonesia,
Yes.
the National Board for Family Planning, and also for contraceptions program. So it could be the thought could be implemented nationwide, not only for some specific audiences like us, but until the grassroots for making execution in the field for this. If otherwise, all will be the same, business as usual. Everybody get contraception. Everybody get the intrauterine device. Yeah. So this is very, very interesting. So the next we have Dr. Wisnu Prabowo that would like to give some of his idea or maybe some question, please, Dr. Wisnu Prabowo.
Yeah, thank you, Dr. Adri. Assalamualaikum warahmatullahi wabarakatuh. To Professor Budi Wiweko, Assalamualaikum Prof. Iko. Very interesting lecture, Prof, about the total fertility rate. I want to know about the total fertility rate in global, like the China. We know that China is one child program now to the 2-child program. I think this the total fertility rate decline, and I think I'm interested about the IVF. Prof. Iko said in the slide, the many couple, maybe many people delayed married, and the married couple maybe delayed pregnancy. So the couple or the people go to IVF program. I want to know about the quality of sperm or ovum or eggs to the next if the pregnancy. How about quality in the pregnancy, Prof. Iko? Is delayed married or maybe the delayed program in pregnancy? Thank you, Prof. Iko.
Please, Prof. Iko, for
Yeah.
the answer.
Yeah, thank you very much, Dr. Wisnu, for very interesting questions. Number one, I think the China, the total fertility rate China right now is 1.3 or 1.4. Even they have already stopped the one-child policy, becoming a two-child policy. But still, yeah, the total fertility rate is below than 2.1. However, they have a very huge population. I think 1.8 billion. And then China right now, because of the strong government, they have very strong policy, yeah, to establish the high quality of human resources through education, research, and innovation. They send all the young people to study abroad. And then right now, I think they harvest the result. The many young people right now in China, many PhD, the bright PhD, the bright student, the bright professor. So that's why they are now very, very developed countries. I think China now in the peak of the bonus demography, because the appropriate policy by the previous government, the Xi Jinping, something like that, Xi Jinping, the very hard government. I think this is one of the successful of the policy in China right now, and then they now become a superpower country, I think. This is the importance, the high quality of human resources. And then the second thing also is very sharp question about the quality of egg and then the sperm in the late married couple, of course. This is a very important point. Not so easy to get the pregnancy when the female already above 38 years old, because the probability of one egg to become one normal embryo is only about, I think, at less than 10%, only 5%. If the female married at the age of 40 years old, the probability for one egg to become one normal embryo only less 5%. So it means to get one normal embryo, we should at least get 20 eggs. So it's not so easy, not so easy. So that's why now many technologies was developed to increasing the result, the quality of the result of IVF, especially in we call it the poor responder patients, when they getting married late. Then that's why also one of the technology is fertility preservation. How the people right now, how the female right now, they go to the clinic and then to have the social egg freezing services. So they freeze their egg when their age is less than 30. I think this is become growing in the world, also in Indonesia. Yeah, even still many pros and cons, but this is the situation currently was developed in across the globe, I think. Thank you, Dr. Wisnu, Dr. Adi.
Thank you very much, Prof. Iko. Thank you, Dr. Adi.
Yeah, thank you, Dr. Wisnu. Prof. Pisek has already raised hand. Please, Prof. Pisek.
Yes, thank you very much, Dr. Wisnu, for your question. I can give you some information for Thailand. 10 years, more than 10 years ago, the number of delivery per year in Thailand was more than 1 million. But over the past few years, it dropped down to about 500,000 and decreasing. So the total fertility rate now in Thailand is 1.3. And last year, it was the first year that Thailand population start to decline. So our population will not reach 70 million because our population is declining. The government now has offered for those couple with infertility problem to receive the artificial reproductive technology, maybe for 2 cycles. The government will be responsible for the cost, but only for 2 cycles. I don't know whether this will increase the fertility or not. That is the information from Thailand, Dr. Wisnu. Thank you very much.
Thank you very much, Prof. Pisek.
Yeah, very interesting information, Prof. Pisek. So, government is stimulating to choose the pathway of giving a subsidized for the couple that it's considered infertile and want to have children. Yeah, for the policy right now. Yeah, for the time being. So for the next occasion, Dr. Nutria is already waiting for to make comments, idea, or asking question. Please, Dr. Nutria.
Thank you, Dr. Adrianus. Very amazing lecturer from both of Prof. Iko and Prof. Pisek. I'd like to ask question to Prof. Pisek. Maybe we are interested in the evidence-based medicine in developing countries. Can you explain what is the first step can we take for us to start research on maternal evidence-based medicine to be able to create evidence-based maternity care to reduce maternal mortality? Perhaps you can tell us about what kind of topic we can start. Thank you.
Thank you very much indeed, Professor Nutria. I strongly recommend you to contact my colleagues, Professor Detti at University of Gadjah Mada, who is currently looking after Cochrane Indonesia. And when listening to my very dear colleague Budi lecture, I think one of the main problems in Indonesia regarding maternal fetal medicine, especially in the public issue, is about maternal anemia. Maybe this is your routine question. I think this is the most important question to work with. obtaining evidence from the research, maybe looking at the WHO recommendation, what are they recommending. They also provide research recommendation, research implication. Maybe you can look at that recommendation. What type of research that we still need more information on that? And I'm sure my very dear colleague, Detti, and I promise that we can work with you on developing maybe Cochrane review or implementation of the WHO recommendation. The other issue that Budi and I try to work together is about trying to get low-cost carbetocin for the prevention of postpartum hemorrhage in Indonesia, because Ferring has promised us to give low-cost carbetocin, his stable carbetocin for lower middle-income country. I'm sure that Budi is working on this, and maybe that is another issue that can save more women's life from postpartum hemorrhage. Thank you very much. Maybe Budi, you can support me.
Yeah. Thank you very much, Pisek. Yeah, as you mentioned, right now we are in the processing of the getting approval from the Indonesian FDA. Then hopefully, by this year, by the end of this year, we can get approval of the low-cost carbetocin for the postpartum hemorrhage, and then afterwards, also we can creating our own evidence, how to use how the outcome using the low-cost carbetocin in preventing postpartum hemorrhage. I think this is will be the good evidence from our country. Thank you.
Nutria, I emphasize anemia in pregnancy. I think
Yes.
to me it's very important issue in Indonesia.
Yeah,
Thank you, Prof. Pisek.
strongly agree.
Okay, thank you, Dr. Nutria, for the very great and intriguing questions. And now we are going to Dr. Robert Ridwan. Please, Dr. Robert, share your thoughts or ideas or comments and questions.
Thank you, Dr. Adri. Thank you, Prof. Iko and Prof. Pisek for the presentation. That's an amazing presentation. Back to your discussion for Prof. Iko. Back to your first slide in your presentation. You review about the elephant in the room. In my opinion or in my suggestion about the fertility, connecting to the fetal medicine, especially in fetal maternal medicine. In my opinion, when we push or gain the fertility rate, it means homolog or connecting to the maybe increasing of the mortality rate or something like that, and then maybe connecting to the stunting and then the other problem. And in my question, is there any suggestion from the government, I think, or from the Society of Obstetric Gynecology to reduce about the risk factor when the fertility rate increase? It means we will meet the next obstacle like stunting. That's the first question, and the second question is, we know in Indonesia we have bonus demography in 2030 until 2040. I think with the bonus demography, we have the challenge to increasing about the fertility rate, but sometimes, yeah, like Dr. Adri said before, nowadays the many couples prefer to get friends with benefit status rather than the formal marriage. That's why the problem is not only about the curing, but I think the main problem, yeah, we have to make like decision or make like opinion to the couple, especially in the potential couple, to how to change about the perception of the marriage. I think that's my question, Prof. Thank you, Prof.
Yeah. Yes. Thank you very much, Dr. Robert, for very burning questions. Number one, Your statement is quite true. It is quite right. How the concept of the family planning is how to start a good family. This is very important. So if we can classify it into three compartments. The first compartment is preconception before pregnancy, and then the second compartment is during pregnancy, and then the last compartment is after delivery. This is very important. How the government support the program of family planning. The preconception. This is, I think, the most crucial step, as you mentioned. I think David Parker mentioned about the first 9 months shape the rest of your life. But before the patient getting pregnant is much more important. How we preparing the pregnancy? Let's say, I always mention in my lecture, in our country, we found a lot of wedding organizers. We found a lot wedding organizers. In each city, maybe every city, we find a lot wedding organizers. And then the people want to pay billion rupiah or even a million, 100 million or even billion rupiah to pay wedding organizer. But we never talk about pregnancy organizer. This is much more important, pregnancy organizer, than wedding organizer. So the people preparing, starting from children, starting from teenagers, starting from adolescents, how the female life, how the male life, how they prepare, how they keeping the reproductive health. If we mention the definition of reproductive health according to WHO, not only the healthy issue in the organ, but also the function. The function means to having a baby. How the vaccination, how the nutrition, how the lifestyle, how the environment to preparing the young generation to start the family. Even the country right now, every country in the world, they did their own human genome project. For what? For preparing the new generation. Starting from the very, very primary prevention. When the baby was delivered, we know, we should do they did the biomarker mandatory testing to see how the gene susceptibility, what is the disease they have, maybe potentially in the future. And then we should change lifestyle and then environment appropriately to avoid the diseases, to starting the family in the future. So this is very important. So when the female getting pregnant, they do not only pregnant her children, her daughter, or her son, but maybe her granddaughter. This is the concept. And then this is our country, Indonesia, of course, is mandatory to preparing how to start the family. I think this is the key. You mentioned to avoid, of course, to make a pregnant woman healthy, avoiding the maternal morbidity, mortality, stunting, everything. So I think this is the key. And then the second questions about the
Bonus demography, Prof.
yes, the bonus, the demography, the same. I think how the government should keep all the people in the reproductive age and childbearing age. So reproductive age is from starting from 15 to 64 years old. They should help the healthy people and then productive people, all the employment, or they have the as an entrepreneur. I think this is the most productive one. The successful of the China, we should learn a lot. This is 15 to 64. They are very productive. Not only in the daily activities, but also in the term of research and innovation. Remember that the technology, education, science, and technology will leading the world. This is a knowledge-based economy. So every country right now, they should have a good knowledge, science, and technology, to establish their own country. I think this is very important for us. And then let's say now we only have almost 20 years from now up to 2045, increasing the aging people. This is our hard work. How to keep our aging people stay healthy and then stay productive. I think this is the way Indonesia should do to keep the bonus demography still stay until 2045. Thank you, Dr. Robert.
Wow, very, very complex and very difficult matters to discuss. Well, thank you very much, Professor Budi Wiweko. Actually, we are already running out of time, but I think we still have one panelist to making questions. But I would like to give opportunities from the chat box. Maybe I choose one from the chat box, asking to Professor Pisek regarding how do we minimize the bias in research synthesis. Do you have like some sort of a point of tips and tricks for minimizing the bias in doing the research synthesis, Prof?
Thank you very much for this extremely important question. In research synthesis, following Cochrane policy, they are very strict on risk of bias assessment. So for each include study, you have to do risk of bias assessment depend on the study design, in which we are mainly covering the randomized control trial. Now, not only risk of bias assessment, Cochrane is including one more issue about this bias. It is about the trustworthiness. So on top of list of bias assessment, now we have trustworthiness assessment, in which the WHO also has recommendation on this. Again, Cochrane Indonesia can provide you more detailed information. Thank you very much. I can have one issue after Budi. Budi, I'm very interested in wedding organizer. Maybe as the incoming president of Proxy, maybe one of the package of wedding organizer is to ask them to give some information about the pregnancy population. Thank you.
Thank you, Pisek.
Yeah, very nice idea, Professor Pisek. Very nice. So for the last panelist, we will give opportunity to Dr. Lini Asthetri to have your ideas shared or your thoughts and comments regarding topics that we are discussing today.
Thank you, Dr. Adri, as our moderator this afternoon. For Prof. Budi Wiweko and Prof. Pisek, thank you for your lectures. It was an amazing lectures. Maybe I have one question for Prof. Iko and one for Prof. Pisek. The first question for Prof. Iko about your presentation about the declining of fertility rate. I have a question. Maybe you can share about your thoughts. Maybe what are the problems that may come in the future if fertility rate continues to decline, especially a problem for us obstetricians and gynecologists, Prof. And then for Prof. Pisek, about your presentation about research synthesis. How long does it take to carry out a research synthesis, and what influence the research so that we can have the best results, and then we, the results can be applicable to our daily practice? Thank you, Prof.
Yeah. Yes, thank you very much, Dr. Lini. This is really interesting and challenging questions. If you think, let's say, within 10 years ahead, because of declining of fertility rate in our country, what happened with us as an obstetrician? Of course, number one, if the fertility rate is declining, so aging female was increased. And then as a gynecologist, the concept of reproductive health is from womb to tomb. So we are facing the older female with the gynecological problem. Let's say malignancy, urogyne, pelvic organ prolapse. We are facing a lot of problem with that. Then we are facing about the menopausal problem and then metabolic syndrome, cardiovascular problem in the female, something like that. So as a gynecologist, that's why nowadays it's quite developed the gynecological practice for preparing the healthy women when they are getting older. I think this is the most our homework. And then the second thing, how about the obstetrician? Of course, the delivering the baby, the number of delivery is declining. Let's say right now, 1.5 million, maybe getting declining up, maybe getting 3 million or 2 million. Of course, the number of fetal delivery is decreasing in the hospitals, and then increasing the number of fertility. So that's why the reproductive endocrinology and fertility, there's a lot of homework. The people facing about the fertility, reproductive diseases such as ovulation disorders, the cyst and the matrix disease. I think they should change. And then also the obstetrician, the maternal fetal medicine are facing a lot of problem in the pregnancy. Yeah, a lot of problem with the quality of the pregnancy, the quality of egg. They become problem with the quality of the embryos, the quality of the pregnancy, increasing the early preeclampsia, something like that, and then many maybe abnormalities correspond to the genetic problems. That's why in the future, the fetal surgery, even the gene editing is quite important to address the issue, the genomic problem before the pregnancy or during early pregnancy or during embryos. I think this is the future of our problem in ONG. Thank you.
Thank you very much, Dr. Lini, for your practical question. Again, I would like to emphasize if you and your colleagues are interested in research synthesis, to start with your routine work. For example, as we discussed earlier, anemia in pregnancy seems to be a very important problem in Indonesia. So maybe you can work on this. I have been working with Cochrane over the past 20 years. And the process of doing Cochrane review is to start with register the title with them. This is to allow repetition so that we don't have to do what people are doing or have been doing already. We need to do something that are still lacking. So they request us to register the title that we want to conduct the Cochrane review, and they can give comment and suggestion. After your title has been registered and accepted, Cochrane allow you 6 months to develop their protocol. And they have all the tools for you to develop. They have handbook, they have consultation, they have self-learning, so you can do that. They allow 6 months, but with some relaxation. Maybe within 1 year is still okay. Then you publish your protocol in Cochrane Library after peer review by the Cochrane staff. Now, they usually search all the literature for you and give you the full text if those full texts are not available in your institute. Then you conduct your review, and they allow you to have 1 year in completing the review. So 6 months and then 1 year. And then after peer review process, they publish your Cochrane review in Cochrane Library. And theoretically, Cochrane requests us as a review author to update our Cochrane review every 2 years, so that our Cochrane review will keep up to date, so that people can use our Cochrane review. And I still recommend you to contact Cochrane Indonesia in Kacamata University. I am sure that they will be willing to help you. And you also can contact me if I can be of any help for you. Thank you very much.
Thank you, Prof. Pisek. A very nice question. So Dr. Lini will make a question today, and we will see the answer 2 years later on the journal. Okay, Dr. Lini. with collaboration, of course, with the Cochrane, with Dr. Detti, Prof. Ova, Professor Hakimi in Gajah Mada University, and also in here we have Professor Sulistiowati and team also to collaborate together. So I think we are already over for quarter hour. It's because it's very, very colorful and fruitful discussion. Maybe we are not really recognize that the time has already over for 15 minutes. Thank you very much. So due to the amount of time, I need to wrap up this wonderful event, this world-class university lectures from two of our distinguished lecturers, international lecturers. We would like to state our biggest gratitude and appreciations for Prof. Pisek Lumbiganon from Konkan University. Please make applause for the audience for Prof. Pisek Lumbiganon. And Professor Budi Wiweko from Universitas Indonesia. Please give appreciation and applause also. Yeah, this is very interesting for us to have key messages from both of our lecturers. If we are not using evidence-based medicine for our clinical practices, daily practices, and even for the making a decision for policy or consensus, it's like we are walking with a closed eye, and it will make a disaster, and it even make a very big disaster if it is being used as the policy without any evidence-based medicine. Policy without evidence-based medicine will make an impact on the national or even the regional or international. It's very dangerous. And also about the elephant in the room. The elephant should be riding not only 1-2 persons, but for all of the stakeholders, the government, the university, the schools for educations, from the practitioners, the clinician, OBGYN, and also from the community. All have to bear hands together and rise up this concern regarding fertility rate, because this is problematics not only for Indonesia, not only for Thailand, but this is the problems for the worldwide, the problem for the international and globally. Thank you very much, and we would like to give appreciations to the Faculty of Medicine of 11 Maret University, the International Partnership and Collaboration Office of the 11 Maret University, Obstetrics and Gynecology Department of 11 Maret University, the undergraduate program of the School of Medicine, the Faculty of Medicine of 11 Maret University, and also for the Master's and PhD program from the Public Health of the Faculty of Medicine of 11 Maret University, and also for the midwifery programs, educations of the Faculty of Medicine and 11 Maret University. Thank you very much. And also for the Indonesian Society of Obstetrics and Gynecology, mainly for the branch in Surakarta, Solo, Indonesia. Thank you very much. Already joined us, and also for the alumni of the 11 Maret University Specialist Program. For the students, for the undergraduate students, for the postgraduate students, for the co-assistancy, for the residency, for the specialists that has already joined with us from the beginning until the end of the events. Thank you very much for your kind attentions, for your kind willingness to stay and gather with us for the thought and ideas. And for the organizing committee, all of the teams, thank you very much that already make this event could be done successfully. Thank you very much for your kind attention, and we are close this session by saying goodbye. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Have a nice weekend.
Thank you. Thank you very much. Thanks, Adri, Pisek. Thank you, Pisek.
Terima
Prof.
kasih.
Sulis, thank you.
Yeah.
Dr. Robert,
Thank you,
semuanya.
Prof.
Terima kasih.
Ya,
Thank you. See
semuanya.
you,
Matur
Pisek.
nuwun.
See you next month.
Yes.
Atur suwun,
See
Prof.
you. See you. Okay, bye. Thank you, Adri. Matur nuwun. Assalamualaikum, Prof.
Waalaikumsalam.
Ya, matur nuwun. Yeah. Sampai ketemu di Kupang.
Iya.
Ya, ya. Siap.
Terima kasih. Kita tutup ya, Prof. Untuk
Ya, nggih, silahkan. Alhamdulillah sukses. Saya izin live nggih. Adri mute.
oh ya. Baik, Prof. Kita tutup. Silakan ditutup. Terima kasih.